Like the Greeks sailed the 7 seas, I'll try to sail the 7 minutes and see if I'll be successful. I want to congratulate the organizers for really a wonderful, world-class conference, and I'm humbled by sharing this with really world experts here. And if I make some mistakes, just humor me. As a proponent of PV loops, I've always showed this slide and pointed out that for decades we have spent time on the body, focusing on blood pressure and cardiogenic shock, dousing people with inotropes while we're forgetting the heart, while the energetics of the heart and the load on the heart is beautifully reflected by pressure volume loops. I want to thank Marwan for giving me this topic, because I started thinking, now that we have recognized cardiac support, we probably are forgetting that tissue perfusion of the rest of the organs is more than just blood pressure and lactate, and I think that's been factored in. It's not those patients who are hypotensive that we have a problem with, it's the patients who are not hypotensive who can still be in shock that we run into problem. So understanding the fallacies of the current markers, and also understanding that lactate can be elevated just by the fact that you're on epinephrine, the beta stimulation between aerobic and anaerobic glycolysis can make your lactate high and not reflect tissue perfusion. So there are limitations, not going into why blood pressure and lactate are not enough. I want to point out that when you look at the blood flow to the body, we look at mentation, we look at urine output, we look at liver function, we look at kidney failure. That's perfusion, perfusion to the organs. So the goal, why do we have to assess perfusion? Because you can have a good heart and the impella save the heart, but if the body dies, there's no point, there's no human being there. You want to have a baseline risk prognostication to assess the resources that you want to invest. We also need to understand the adequacy of escalation and probably on de-escalation, as we are talking about, and then appropriately decide futility of care. When you look at organ level perfusion and try to define what do we define perfusion as? This study, CardShock, European study actually has done a lot of these end organ studies, but if you look at the graphs, it's the ALT that stands out, not AST for whatever reason. A change of ALT, worsening of ALT of greater than 20% within the realm of 12 to 24 hours separates the graphs quite remarkably. The lower end of the, sorry, can you go back? Actually, there you go. The pointer, I don't think I have the pointer for the screen, so I'm going to point out to the one on your left. The lower left is the cardiac index, and if you look at individuals whose ALT gets worse versus not, it's the cardiac index that makes the difference, suggesting this could be perfusion mediated. CVP and congestion always comes into the picture when you look at parameters of tissues being soggy versus getting less oxygen. And interestingly, in this study, whether your ALT got worse or not, your CVP was about the same. The ASCEND-HF study analysis, which is not shock, it's just heart failure, interestingly showed that AST, ALT were not prognosticated, were not accurate to predict the outcomes, but the total billy was. In my clinical experience, I pay more attention to total billy, and interestingly, the biliary pumps that pump bilirubin out from the portal triad are the most highest energy utilizers in the liver. So it makes sense to me that your perfusion and oxygenation might be related to total bilirubin. Kidney function is always measured as a marker of perfusion. We heard some comments earlier. But if you look at this study, again from the CardShock study, it shows that the KDIGO's definition of urine output, which is 0.5 ml per kg per hour, does not hold true for prognostication. You either have to use creatinine, in the model 3 listed over there is the control model, AKI by the definition of creatinine, or a modified urine output less than 3 ml per kg per hour for 6 hours holds relevant. And I don't know where I should point. Oh, there you go. These were the definitions. I'm going to skip the definitions. But again, when you look at those 3 graphs, MAP followed by index versus the CVP, the individuals whose creatinine measurement defined them as AKI did not have the cardiac index improve, which again comes down to a surrogate of perfusion. Now, systemic perfusion can be measured by cardiac output. By now, if you're still a Swan hater, you shouldn't be in this room. I think there's no reason to hate them. Using them appropriately, measuring the oxygenation is extremely relevant. But when you're getting all this information from the Swan-Ganz catheter, it's important to understand that the oxygenation delivery is what we're looking for, but the tissue extraction is extremely relevant. And your organs can't just get oxygen from anywhere if you're not supplying enough flow. So oxygenation can be a marker, flow can be a marker of oxygen delivery, but remember though, flow is not equal to perfusion. Perfusion is an intentful flow for effective tissue utilization of what they're trying to deliver. I want to point out that in the Swan-Ganz catheter, the output that comes out, there are two different techniques. So your oxygenation is the most absolute value. Your output is the thermodilution technique. Both are different. So if there's a disparate assessment, you want to go to the objective oxygenation. The problem is there's lack of strong evidence of using a goal cardiac index or SVO2. And if you think about it, it comes down to also microcirculation. This is a graph showing there is a lot of factors that go into tissue perfusion and reserve in the endothelium. And you can't just generalize it to every other individual. It comes down to how can we measure perfusion. This is a mottling score. We should not even look at it because we shouldn't wait until that time. And there are other techniques that are coming up where you can actually measure skin perfusion. And this is a study in sepsis showing that if your skin perfusion improves, you do better. And then a list of things that can be done with temperature and assessments. But we're moving towards what we need to define as door-to-tissue perfusion. And that's really where once we identify what tissue perfusion is, but the future should hold on understanding cellular impacts of lack of blood flow, which includes local metabolism. And maybe you'll have a scan in the future that will alert you no brain perfusion, no kidney perfusion that you can use to then decide that you're not perfusing appropriately. My slides didn't go off, actually. Thank you.
Questions? Yes.
Great. Are you using any kind of cerebral? Are you routinely per protocol with NIRS or anything else looking at target, especially cerebral perfusion in some of these patients who are you just riding that blood pressure basically at 60?
The straight answer, no. We've started using TCDs in intra-operative settings for high-risk individuals because we've had the same debates on what is the right perfusion in some individuals post-transplant, but not routinely. It takes a little bit. We have TCDs. We have a whole research group. It takes a little bit of effort for people to be there and look at the TCDs regularly. Now, we're not doing it actively, but I think that's an opportunity to explore.
So, Arvind, what about your simple CCO Swan? They were the one that gives you the little laser tip on the end, tells you the estimated SVO2. Is that valuable to you?
Definitely, and I think there's a lack of evidence, and I think, David, we had talked earlier, I'd asked saying in the shock study, if you go back and look at, is there something to time to SVO2? Can we segregate the population and say, if it took 6 hours for us to reach an SVO2 of 70, do you do worse than if you reach 3 hours? I know the sepsis world had this 70 goal for the sepsis resuscitation, but I think that needs to be replicated in cardiogenic shock, because I think there is something to time to reaching tissue perfusion. If you use SVO2, do we use it clinically? Yes, in some extent, but I think we still go back to our old habits of putting all the information together, because you also want to ask the same question if you're looking like a rose, like we talked before, and you have an SVO2 of 37 and a MAP of 80, are you going to escalate your care and put in an Impella beyond that? So I think we need more data, but in my clinical practice, I do notice that if you have a mixed venous that is lingering in the 20s, 30s, patients looking good, we're on a balloon pump, we think we're doing okay, they don't do well. I think you need to escalate the care at some point. It's the question of chronicity of their illness versus an acute effect. But it's very important to use the central venous saturation, preferably the mixed venous saturation, because the studies show a difference between a central venous versus mixed, and use that as a goal for appropriate resuscitation, I think.
Great. Thank you, Arvind. Thank you so much.